Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
We are living in an incredible time for medicine. We're developing cures for diseases that we used to think were a life sentence, and we're doing it with therapies made from living cells. But with that incredible power comes some pretty incredible risk. See, we're not just stamping out pills anymore. We're literally engineering life. And to do that safely, we've had to build a kind of invisible fortress. So today, we're going to take a look inside.
To really get a sense of the challenge, just look at this. On the left, you've got good old aspirin, a simple, predictable chemical made of just 21 atoms. On the right, that's a monoclonal antibody, a type of biologic. It has over 25,000 atoms. This isn't just a difference in scale, folks. It's a complete quantum leap in complexity. And that changes absolutely everything. So that massive leap in complexity, it forces us to play by a whole new set of rules. There's one fundamental principle that governs this entire field, and it's an idea with some seriously huge implications. For these new medicines, the journey itself is the destination. And here's why. Unlike a simple chemical like aspirin, which you can make exactly the same way every single time, biologics are grown inside living cell systems. And just like any living thing, there are always going to be tiny, natural, unavoidable variations from one batch to the next. You simply can't make a perfect carbon copy. Which brings us to the core mantra of this entire industry. You'll hear this over and over again. The medicine isn't just the final formula in the bag. No, it's the entire validated manufacturing process. Every single step, every temperature change, every little quality control check along the way. If you change the process, you have fundamentally changed the product. Okay, so if the process is the product, how on earth do you manage the risks at every single one of those steps? Well, it really boils down to thinking about two key things: the agent you're working with and the procedure you're performing with it. So how do you actually do that? How do scientists build a safety net to manage all these invisible biological dangers when there are just so many variables? Well, you definitely can't just guess. You need a methodical, systematic way to think about it. And that systematic approach is called a risk assessment. Now, this isn't some one-and-done checklist you just file away. It's a living, breathing process. It forces you to look at both the what, so the hazardous characteristics of the biological agent itself, and the how, the specific things you're doing in the lab, like spinning it in a centrifuge that could possibly create an exposure. The whole thing starts by classifying the agent into what's called a risk group. This is basically a rating based on its natural, inherent ability to make a healthy person sick. A really common example is the wild HIV virus. It's classified as a risk group 3 agent because it can cause a very serious, lethal disease. But here's the crucial distinction, and this is so important to get. The risk group is just the starting point. The actual set of protections that you use in the lab codes, the special hoods, the room design, that's called the biosafety level, or BSL. The BSL is the final result of that whole risk assessment, taking everything into account. And this right here is the perfect example of why that difference matters so much. A lot of modern gene therapies use a delivery vehicle called a vector that's actually derived from HIV, that risk group 3 agent we just talked about. But, and this is a huge but, scientists have cleverly engineered these vectors so they can't make copies of themselves. They're replication deficient. So even though the parent virus is RG3, the actual work can often be done safely at a lower containment level, like biosafety level 2. And for these super advanced cell and gene therapies, the risks get even more specific. There's a small chance the virus could somehow recombine and become able to replicate again.
There's a risk the new gene could insert itself into the wrong spot in our DNA and accidentally turn on a cancer gene. The gene being delivered could even be toxic itself. These are the high-stakes scenarios that scientists have to plan for every single day. So, we've identified the risks. Now let's go back to that fortress we're building to contain them. And these aren't just rules on a piece of paper. We're talking about real, physical barriers and procedures that get more and more intense as the danger level rises. The foundation of this fortress is Biosafety Level 2. You can think of this as the minimum standard for any lab handling human-derived materials. The key here is working inside special ventilated hoods called biosafety cabinets, especially when you're doing anything that could kick up aerosols. The lab itself also has basic safety features, like doors that lock and close by themselves, and an eye wash station, just in case. So what if the risk is a little higher than your standard BSL-2, but maybe not high enough to require a full-blown BSL-3 lab? Well, that's where this unofficial level called BSL-2+ comes in. The single biggest upgrade here is inward directional airflow. Basically, the lab is kept at a negative pressure, which acts like a gentle vacuum, constantly pulling air into the room. That way, nothing can accidentally drift out. Now, the jump to BSL-3, that's a major step up. We're talking about agents that can cause serious or even lethal disease if you just breathe them in. At this level, the facility itself becomes an active piece of the safety equipment. You have to enter through a 2-door airlock, and the air system is completely separate. It's on a dedicated, one-way trip. Air gets pulled into the lab, goes through heavy-duty HEPA filters, and then it's safely exhausted outside. This table really makes the differences crystal clear. Just look at the airflow. You go from standard building ventilation at BSL-2 to that dedicated, single-pass filtered system at BSL-3. Access goes from a simple locked door to a strictly controlled 2-door interlock system. And the waste? At BSL-3, every single thing has to be completely decontaminated before it can even leave the room. All right, so we've spent a lot of time talking about protecting the scientists and protecting the environment. But what about protecting the patient? That's where we shift gears a little bit, from biosafety to a related set of rules called Current Good Manufacturing Practices, or CGMP. This is all about protecting the product itself. And the absolute ultimate test of a CGMP process is something called an aseptic process simulation, or more commonly, a media fill. The best way to think about this is like a full dress rehearsal for a Broadway play. You go through every single step of the manufacturing process exactly as you would for a real patient. The only difference, instead of using the actual cells, you use what's basically a sterile soup, a growth medium that will immediately show you if even a single stray bacteria gets in. So, you've run this perfect simulation of your process from start to finish. You take the final product, you put it in an incubator for 2 weeks. What's the passing grade? How many contaminated units are you allowed to have? The answer is this number: 0. That's right. For these incredibly powerful medicines that are often injected directly into very sick patients, the standard isn't pretty good or almost perfect. The only passing grade is absolute verifiable perfection. If even one unit shows contamination, the entire test is a failure, and you have to figure out what went wrong and start all over again. You know, all these systems, all this amazing engineering, it's incredible. But at the end of the day, it's only as good as the people who are running it. The human element is the final and maybe the most critical layer of control in this whole fortress. So what happens when things do go wrong? Well, if there's a spill outside of a biosafety cabinet, there's a clear, immediate procedure. First, you alert everyone and get out of the area. You close the door on your way out to contain anything that might be in the air. Then, you wait. You have to wait at least 30 minutes for any of those potential aerosols to settle. Only then can a trained team go back in with the right protective gear to decontaminate the spill. Every step is about control. And what if someone is directly exposed, say a needle stick or a splash to the face? First aid has to be immediate. For a cut, you wash it with soap and water for a full 15 minutes. For a splash, you flush your eyes, nose, or mouth at an eye wash station for 15 minutes. And then comes the most crucial step of all. You report all exposures to a supervisor immediately. There is no such thing as a minor exposure. Every single one requires a medical evaluation. And all of this leaves us with one final big picture thought. We are charging into a new era, where medicine is no longer a static chemical in a bottle. It's a living, dynamic therapy. So the ultimate challenge for all of us is this: how do we make sure that the invisible fortress we build to protect it, the complex science of safety, is just as advanced, just as dynamic, and just as alive as the cures it makes possible?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.